Today, let's talk about clinical efficacy and safety of early intravenous administration of beta blockers in patients suffering from acute ST segment elevation myocardial infarction without heart failure undergoing primary percutaneous coronary intervention, a study level meta-analysis of randomized clinical trials. Several clinical studies have produced diverse results regarding the efficacy and safety of early intravenous beta blockers in patients with acute ST segment elevation myocardial infarction. A study level meta-analysis of randomized clinical trials comparing early intravenous beta blockers versus placebo or routine care in ST segment elevation myocardial infarction patients undergoing primary percutaneous coronary intervention was performed. Coming to the methods, a database search was conducted using PubMed, EMBASE, the Cochrane Library, and clinicaltrials.gov for randomized clinical trials that compared intravenous beta blockers versus placebo or routine care in STEMI patients who underwent primary PCI. The efficacy outcomes were infarct size and the myocardial salvage index based on magnetic resonance imaging, electrocardiographic findings, heart rate, ST segment reduction percent, and complete SCR. Safety outcomes included arrhythmias in the first 24-hour, atrial fibrillation, bradycardia, and advanced atrioventricular cardiogenic shock and hypotension during hospitalization, left ventricular ejection fraction, and major adverse cardiovascular events at follow-up. Coming to the results, 7 RCTs with 1,428 patients were included in this study, with 709 patients in the intravenous beta blockers and 719 in the control group. Intravenous beta blockers improved MSI compared to the control group, but no difference were observed in IS between groups. Compared to the control group, the intravenous beta blockers group had a lower risk of ventricular tachycardia and fibrillation. Compared to the control group, the intravenous beta blockers group had a lower risk of ventricular tachycardia and ventricular fibrillation without an increase of atrial fibrillation, bradycardia, and atrial ventriculation block, and significantly decreased HR hypotension. Left ventricular ejection fraction at 1 week plus minus 7 days was improved in the intravenous beta blocker group compared to the control group. Subgroup analysis showed that intravenous beta blockers before percutaneous coronary intervention decreased the risk of ventricular tachycardia and ventricular fibrillation and improved left ventricular ejection fraction compared to the control group. Furthermore, sensitivity analysis showed that patients with a left anterior descending artery lesion had a smaller IS in the intravenous beta blockers group compared to the control group. To conclude, intravenous beta blockers improved the myocardial salvage index, decreased the risk of ventricular tachycardia or ventricular fibrillation in the first 24 hours, and were associated with increased left ventricular ejection fraction at 1 week and 6 months following percutaneous coronary intervention. In particular, intravenous beta blockers started before percutaneous coronary intervention is beneficial for patients with left anterior descending artery lesion.